Would you mind to just in the front, to be around? Dr. Magdi Haggag, Dr. Arku from Poland. I know that. You can have a seat here. Dr. Saeed Abaziz, he's already. Dr. Said Ali Sharif Kirdawi is around. I saw him. Dr. Sharif. So let us start, Dr. Hussein.
First of all, I thank the organizing committee for the very kind invitation, in particular Dr. Nasser Saeed. And I have the honor to moderate this session. And we start with Dr. Gabriele Pifariti from Italy. He will give a talk on the Insitue fenestration with the LifeTech Ancura stent graft system for left subclavian preservation.
Thank you so much.
And then we'll have an open discussion.
Okay. For the kind introduction, let me express my sincere gratitude for being here in such an outstanding environment and context. So the policy of our institute regarding the preservation or revascularization of the left subclavian artery during zone 2 TIVR has changed significantly and progressively along the course of the last 2 decades, starting from the intentional occlusion policy in the very first phase of TIVR down to the revascularization by default until the most recent advances in total endovascular solution for the distal arch. As you can see here, preservation or revascularization of the left subclavian artery has been the mainstay of treatment in zone 2 TIVR, and at least in our institution has been made primarily by open surgical approach, conventional prosthetic graft bypass, no transposition. In-situ fenestration should be considered an option for zone 2 TIVR for a total endovascular solution. We have already abandoned the parallel graft techniques because of the mid to long-term issues regarding misplacement of the components. We have started a very preliminary experience with custom-made scallops and fenestration or single-side branches have never performed physician-modified and bench endograft solution. In comparison with all of these alternatives, as you can see here, Insitue fenestration has quite good results and outcomes in considering the most important TIVR-related endpoint. There are some concepts and importance of material beside this technique. There are other alternatives to do the Insitue fenestration. Radio frequency has been already abandoned. Laser has the more robust cohort so far, but has been abandoned in favor of the high technical success and good results of the adjustable needle Insitue fenestration. There are some fundamental, crucial concepts behind that. For sure, anatomy matters in the abdominal, in the thoracic abdomen, why not in the arch? So we can think about the ideal situation to have an arch with a 90-degree takeoff of the left subclavian artery. This is very crucial, the starting point in association with a good proximal landing zone of at least 10 millimeters in length. So that is important in terms of materials. We are using this type of endograft, the generation 2 of the Ancura stent graft, because of its flexibility that is made by the progressive widening of the spiral frame of the stent frame coming from the inner to the outer curvature of the graft. That is made also by a sutured free flow that is covered by a new filament of EPTFE just to make that stent the less traumatic in case of a fragile aorta. There is fundamental aspects in terms of material behind that, also regarding the technique of ballooning after having made the fenestration. Why? Which is the reason why to use the Ancura stent graft? Because in bench test, Ancura stent graft proved to have the slightest resistance, but most importantly, the highest scores in terms of quality of the fenestration holes without additional fabric tears that has been encountered and experienced in Dacron graft. To do that, we have some auxiliary devices, a dedicated steerable sheath, and most importantly, a self-centering balloon-related anchoring adjustable needle, total endovascular needle system to puncture our stent graft in a safely manner. Here are some our institutional cases. Case one has been performed last year. A very obese, morbidly obese patient with a CO2 OSAS syndromes. You can see on the right-hand side of the slide the huge phenotype of this patient with the arch and the saccular lesion at the distal portion of the aorticals. On the left-hand side, you can see the partial opening of the Ancura stent graft, where you can see quite magnificently the radiopacity of the marker that leads you at the proximal edge deployment. Here you can see how important is the perpendicularity of the left subclavian artery takeoff, just to make the most efficacious and the safest puncturing of the endograft. Here in the third slide, the enter of the gauge, and after ballooning, the final results with the bridging stent. That in that particular case, we were forced to add an additional bailout stent because of a delay in the washout of the contrast medium, probably because we were too aggressive, we were very aggressive in that Gothic-like arch. The second case, quite a fragile patient. Please note the sarcopenia index of this patient who came in with a huge aneurysm. Here are the preliminary orthography on your left-hand side of the slide, the deployment of the graft that already excluded the huge aneurysm. Once again, the perpendicularity of the puncturing. Here you can see after just one single shot, the entering of the gauge inside the graft. The progressive ballooning and the bridging stent, and the final results on the right-hand side of the slide. In that particular case, we completed the descending repair because of a huge descending thoracic aneurysm with additional stent graft. The patient did well from a technical point of view. Unfortunately, died because of TAVR unrelated causes. And you can see on the right-hand side of the slide the good apposition and reconstruction of the arch with this new generation device. The third patient who rejected completely any kind of open surgery, a distal saccular enlarging PAU. Probably this was the easiest case that we have done so far. Once again, here you can see the perpendicularity of the steerable sheath to facilitate the puncturing of the graft and the bridging stent to complete. And the last case, a young patient in whom we anticipated a proximal aortic repair just to make easier the repair of this distal arch PAU that was enlarging over time. Once again, here you can see how easy it was to puncture the prosthesis and complete reconstruction with the bridging stent that was pretty clearly flared in a good fashion. So, we have started the data collection in our national territory. It is a multi-center registry-based data collection that involves several centers. Up so far, we have included 18 cases. 70 was completely and successfully completed. All of the aortic diseases has been collected. Fenestration was quite uneventful. We had some additional procedure and results, at least in the early to mid-term phase, was quite satisfactory. May I have some help to gain just a few seconds to give my personal take-home message regarding these techniques and doing the graft, if it is possible.
1 minute more.
So it's a preliminary experience, but technically speaking and clinically speaking, the prosthesis is quite good. Okay, thank you so much. despite the preliminary experience, we have already fixed some new tips and tricks to make the release and the efficacy of this prosthesis the best as possible. Personally speaking, the generation 2 of the Ancora thoracic stent graft has a very good trackability. It is easy to deploy. It has excellent radiopacity. It is very stable during the deployment. You don't, trust me, you don't need any additional very aggressive ballooning of the superior vena cava or additional pacing to make a very precise deployment. It is led by very visible radiopag marker, and it has a very good inner wall position due to the flexibility of the stent supporting structure. Why to choose Insitue fenestration as an option? Well, in my opinion, because it mimics open surgery. It is an anatomic and an antegrade reconstruction. It is too intuitive. Technically speaking, it is not demanding for the surgeon. It is safe. The self-anchoring balloon-based puncture system make it very safe and easy, the puncture of the endograft. That is very versatile. We have briefly re-explored our experience with carotid subclavian bypass that done before the start of this experience, and it is a possibility in up to 90% of the cases regarding LSA preservation during zone 2 TAVR. Thank you so much for your attention. I apologize for the few minutes that I required. Thank you so much.